Pain management has become very popular lately. What is pain management? Well, pain management is actually going to a physician who specializes in managing pain. There's two types of physicians. One is a person who just prescribes medications and therapies, and the other is someone who does injections. Now, this may be one person who does all those things, but frequently they're now divided into two subspecialties where the people that are doing the injections do just injections, and the people that do pain management with medications and therapy just do that. I had a chance to talk to Brad Cash, who is the type of doctor who does medication and physical therapy and some trigger point shots, where he talks about his approach to a patient with a cervical herniated disc.
When a patient first comes to the office and they're having a severe pain, and we make a determination, if we have an MRI and we see maybe they need surgery, maybe they don't need surgery, assuming that they don't need surgery,
Right.
and I'm gonna manage their pain. My first goal is to try to relieve some pain as quickly as possible.
So what does that mean? Is that oral medications or injections or other things?
Right. If they're having a severe pain and spasms and they're very inflamed, I will typically offer them an injection.
Oh, really?
In the muscles around the neck.
Okay.
To try to relieve some of that pain as quickly as
And
possible.
what do you use in the injection? What are the medicines? Is it steroid or is it anesthetic?
So in that injection, I'll typically use a small amount of steroids to reduce the inflammation,
Okay.
and I'll use a local anesthetic, like lidocaine, like the dentist uses to numb your mouth.
And does the shot hurt?
The shot feels like a little pinch and a little pressure, and typically it's very well tolerated, and most patients don't complain of too much pain from this simple type of injection.
Okay, and then you also offer them oral medications to go home with, a prescription to go home with.
Right, then I give them oral medications. If they're very inflamed, if I give them an injection, I'll also give them a 6-day steroid taper.
I see.
To try to help really knock out the inflammation by taking oral medication.
Do you use a Medrol dose pack or do you use your own?
I use a Medrol dose pack.
Okay. And then what about narcotics? Do you consider giving them a prescription for narcotic medications?
Well, also if they're very inflamed, usually they have some degree of spasm, so I give them a muscle relaxer.
Okay.
In addition to the steroids.
And what are the types of muscle relaxers that you use? Like
the most common muscle relaxers are things like Flexeril and Scalaxin.
Okay.
Typically, those are ones that you get in the emergency rooms.
Okay.
And then if they're in severe pain, I'll offer them some type of narcotic medication to take as needed for the pain as well.
And the narcotics, there are short acting and long acting. Do you prefer the short acting or do you go to the longer acting ones for these patients? What is your preference?
Right, so for the newer patients who have a new type of pain or an acute pain, I use short acting medications only. I only use the long acting medications for those patients that have chronic pain.
Okay. And how do you know the dose? Like, how do you know how much to give somebody for this? Is this just experience, or is it something that you really want to? Do you want to hit them hard in the beginning? My philosophy is, when the patients are in pain, I give them a big dose because I think I got to break the pain and bring it down to a level where they can manage. Do you have the same philosophy, or are you different from that?
Right. Well, determining the dose of the patient sometimes could be pretty complex. I'll try to first determine if they've taken any narcotic before, and what their experience was with a low dose or a high dose, to try to get a feel of how much they might require. There are some patients that tell me that they're very sensitive to medications, or that they've never taken a narcotic before. So I start them at a lower dose, just in case. But if they need more, I'll instruct them that they can take an extra pill 45 minutes to an hour later if they're still having pain.
And what about anti-inflammatories?
While they're taking the steroid, I'll tell them not to take any anti-inflammatories, and then I'll instruct them after the steroid's complete, then it's okay to resume any anti-inflammatory medication like ibuprofen.
Okay, and are there other medications? I know there's Ultram, things like that people may have heard about. Do you use any of those, the other ones out there besides the narcotics, steroids, and anti-inflammatories?
Well, medications like Ultram that's a lower level narcotic.
Okay.
So if someone's pain is not so bad, or they're fearful of taking narcotics, I might choose something like Ultram. There are also antidepressant and anti-seizure medications, which are also used for pain, and I'll typically will wait on using those in the newer patient, and typically to try to use those more for the chronic pain patient.
So that would be Neurontin, Lyrica, amitriptyline, things like that?
Yes.
Okay. And then, do you see the patients for follow-up after they leave? I mean, what's your follow-up?
If I give them an injection and medication, I typically want to see them, especially if they're having severe pain. I want to see them 7 to 10 days later.
Okay. And how long do you then follow them? I mean, is it for just that one visit and that's the end, or do you expect to see them back over and over?
Well, if I see them 7 to 10 days later and they're doing much better, I might wait until that point to start them on some therapy, whether it be physical therapy or chiropractics or acupuncture. I don't want them to do any therapy while they're very inflamed.
So as a pain management physician, do you sort of dictate what other will you recommend other things like acupuncture or physical therapy? Are you part of that management?
Yes, I try to decide what type of, not only pharmaceutical treatments or injection treatments can be done, but what type of therapeutic treatments might be offered to relieve their pain.
And when do you choose to send a patient for an injection? Like what's what's the criteria that you use to say, okay, you need an epidural steroid shot from the interventionalist?
Right, if their MRI is indicating a significant disc herniation and they have severe symptoms and they don't get better from the oral medications within the first week or two, then they might say, well, you need an injection. I think the injection could be a little more aggressive and can take care of the pain,
Right.
especially down the arm a lot faster.
When you treat a patient with chronic neck pain without arm symptoms, who just happens to have a herniated disc on the MRI, that's a completely different approach. Is that right?
Yes. Yeah, I mean, a chronic neck pain patient with spasms and no pain down the arm, I'm not expecting a radiculopathy. A lot of times those patients have a flare-up of arthritic symptoms in their neck, or they have a muscular, a soft tissue type of spasm which is causing significant pain. And usually we'll approach those patients a lot differently.
And a lot of patients come to me and they're very concerned. They have an acute herniated disc, they have pain on the arm, and they're really concerned about using medications, narcotics. They don't want to get addicted, so people are just dying in pain and they're just not taking the meds. And I always tell them, look, this is the time to take a medication. You're not going to get addicted for this acute type of a pain. Do you deal with that often where you want to prescribe a medication for a patient and they don't want to take it? And what do you tell those patients?
Right, I do deal with that often because narcotic addiction is such a problem in society these days, and so many patients are very fearful of narcotics and getting addicted. And I remind the patients that they're taking this for just a short period of time, just for their pain, and we'll get them to stop the medication fairly quickly, within a week or two, hopefully, and that it's not a long-term solution to give them narcotics.
Yeah. And on the flip side, I'm sure you see patients who are what we call drug seekers who do have addiction problems. How do you deal with those people who show up in pain, and they have a history of drug addiction? How do you even deal with that as far as trying to relieve the pain but not give them medicines that can get them addicted?
Sure. Well, the patients that I know are drug seekers, and now in New York State we have ways of finding out who the drug seekers are. Because of the new New York State registry that started August 24th,
Right.
allows us to look up who was taking what medication, who prescribed it, how much they prescribed, the dose, and when it was filled. So now we have a good indication of who those patients are. So before I go into the room, I can then offer them all types of non-medicine type treatments,
Right.
if I believe that they're just looking for medications, and suggest to them that they obtain their medications from the current doctor that's giving them their medication. I think a pain management specialist should be sought out very early, because then we can assess you and decide what all the possible treatments are moving forward, whether it be medicines or injections or therapeutics. Instead of going to each specialty separately, we can help you decide which pathway you're going to take, and if you need surgery, send you to the surgeon.
So the bottom line in pain management is I love it. I think it's great if you can have someone to manage your pain and manage your care as you heal through this process with a cervical herniated disc. One word of caution though, there are some pain clinics which are really mills where they have a pain management doctor who's there just to prescribe medications over and over and send you to all types of therapy without even meeting or talking to you. Be careful of that. You really want someone like Brad Cash who's there to examine you, to talk to you, to listen to you, and monitor therapies as time goes on week by week. If you're getting better, you don't still need to take these high doses of medications. And be careful with the meds. There's a high rate of addiction in America and a high rate of drug abuse, and you don't want to be hooked into taking these medications. So talk to with your concerns to the doctor about that and make sure that you're not taking too much of the medication. But bottom line, pain management is terrific, and if you can get a practitioner to treat you, go ahead.